Good morning, good afternoon, everyone. My name is Phumzile Mndzebele from Eswatini. I work for PEPFAR. I'm the HIV testing and counseling focal person. And also, I'm also the focal person for the Faith and Community Initiative, and also part of the technical working group that works for that project. Eswatini Faith and Community Initiative. We are seeking to find the missing people by engaging the communities to understand the epidemic, raise community awareness, and bring critical prevention and treatment interventions, including testing to men and women in Eswatini. So the goal is to increase the number of men and women accessing HIV self-testing, and so that they know their status, and then we link them to care and treatment and also to HIV prevention. So the project seeks to increase access to testing services and knowledge of HIV status. To attain that goal, we have 3 pillars. The first one is HIV knowledge and prevention. That includes increased knowledge of HIV, so that it reaches those in need via both community and national structures. Then the second pillar is demand creation. With increased demand for testing services and positive attitude toward testing and treatment services. So we want people to access these services so that at the end they know their state. Then the third pillar, that is the testing services, whereby we are offering testing services through a multitude of delivery channels, which are designed to suit everyone's needs. So specific to increase knowledge of HIV, including prevention and treatment options, for our FCI program, we have trained a number of faith leaders and community caregivers on HIV basics. At national level, we are also conducting health promotion activities and health literacy campaign. So for COVID adaptation, we have increased information directly to congregants. So what happened during the national lockdown, churches were closed. So they created some different platforms where they can communicate with their congregants. Also, we incorporated COVID and GBV prevention materials to our faith leaders, the community carers and congregants. We also used the prevention services whereby people were able to access condoms, PrEP, and IEC. And we had to incorporate some of these IEC materials in our community commodity delivery points, because during the lockdown, as people were not able to come to facilities, we had to design some community delivery points. So with demand creation, because we had to create demand so that people can come for HIV testing. So the messages of hope, again, they were delivered via our community carers, our faith leaders, and IEC materials. We had to adapt for COVID. We had to increase our national media activities, and we had to leverage on what the churches are doing. So it was through the virtual platform, the radio, the TV. We had to do promotion of alternate delivery mechanisms of the HIV self-test. The last pillar, which is HIV testing services, whereby we are offering these services through a multitude of delivery channels. We are using different methods to deliver these services. That is through the faith leaders themselves and the community caregivers, and also by the church members, and also hotline support for testing services. But during COVID, we had to adapt. We had to come up with new strategies. So the first one was the pharmacy delivery, where we had a number of pharmacies in the country that were distributing those HIV self-tests, and also the shopkeeper delivery, whereby we had those retailer shops that were also delivering the HIV self-test. We continued to use our community caregiver strategy, whereby this counselor will be in a designated place at a certain time, whereby people will just come and access those HIV self-tests but we were cautious of the COVID-19 precautions. So this slide is mainly on the distribution that had been done by our community carers and our faith leaders. So we got our kits in February, and there was that sharp increase in March. About 7,520 kits were distributed. Then towards the end of March, there was the national lockdown. And as you can see, in April, there was that sharp decline. We had to come up with some innovative strategies where people can access the test kits. We can see that sharp increase up until June. But now again, we are seeing a decline. Again, people are back to their churches. So I think we'll be seeing a flat line of that number moving on. So what are our best practices? The first one was the robust data collection tools. We had to develop those tools to ensure follow-up on individuals that have received an HIV self-test. Then another best practice was on the strong linkages to confirmatory testing services and prevention. And we were using the existing MOH referral tools and guidelines. Then the third best practice was more on the FCI adoption and adaptation of the MOH HIV self-test screening tool for targeted distribution and faith settings. Thank you so much. And again, I'm available for any questions or comments that people can like to bring forward. Thank you.